Okay, that's 11 o'clock, so thank you everybody for taking your seats, and we're going straight into the next session, continuing the theme, really looking at novel research areas. One of the pleasures of this meeting for me personally has been seeing how engaged surgeons are, not just as tissue collectors for the scientists, but in driving their own excellent research projects. It's my pleasure to introduce Professor Dhanny Gomez to the stage. He's someone who's been very active and whose work I've been following very closely. I'm hugely pleased he's here today. He's going to be telling us about the Nottingham project, combining super slender, agile robot with wireless electrical molecular signaling to tackle cholangiocarcinoma. Thank you.
Thanks, Rachel. Good morning, ladies and gentlemen, and thanks, Helen and AMF, for inviting me to talk about our Nottingham project today. I think this is a very interesting project. The main issue is the bile duct. So, as you can see here, it is extremely slim and it goes into the liver where it bifurcates to right and left ducts. The issue is where the cancers or strictures or growths occur. So you can get one in the distal bile duct. This is the most difficult, what we call the hilar region, where it bifurcates, and you can also get tumors or cancers in the liver. So the first challenge we have as clinicians is reaching a diagnosis. So we usually see scans in our MDT where on a CT it will show that there is a mass or there's a stricture. The question here is, how do we determine the diagnosis? And we put our patients through quite a few what we call preoperative workup, which is the imaging. Most patients in the UK practice, we usually have a CT chest, abdomen and pelvis as the initial staging, and then that's followed by an MRI scan, and now PET scans are more frequently used. We also tend to do endoscopies for two reasons mainly. The first is to drain the bile duct, because most of the patients that present with distal tumors or hilar tumors present with jaundice. But endoscopy also has the advantage of getting tissue samples. And if we are not successful endoscopically, or if the tumor is quite high up in the hilar region, certain centers would prefer to do percutaneous transhepatic cholangiogram. So what are our current issues? So our current sampling methods really have got quite a few limitations. So the first thing is access, getting into a bile duct. The bile duct is extremely thin and narrow, located in a difficult location. So getting there and getting right up to the bifurcation is extremely difficult. And the second thing is accuracy. So processing whatever sampling we get. Did we get enough tissue? Did we get enough cells to come up with the diagnosis? And what we must never forget is every procedure is associated with a complication. And that's really important when we consent our patients whenever they undergo either an endoscopy or a PTC. But why is it important? Because we really need to differentiate whether it is benign or it's cancerous, because the treatment pathway is completely different. And what we look for as surgeons is basically, can we operate on this patient? Does this patient have a resectable tumor which we can potentially cure? For distal tumors, we do a Whipple's. For intrahepatic, we do usually a liver resection and we clear the lymph nodes. And this is the most difficult, the ones at the bifurcation. And so happen, the most common site of tumors for cholangiocarcinoma tends to occur in the hilar region. But the operation is extensive, filled with morbidity and mortality. Just to give you an idea of a hilar operation, so these are all the liver segments in a liver. We have 8 in total. If we're doing a hilar operation, this is what it could mean. We would remove this part of the liver. So we're leaving just a small duct here where we anastomose it to the small bowel. So we decided to start a cholangiopatic study in Nottingham. What were our aims? So the main aim is actually to characterize these biliary strictures more accurately, getting appropriate tissue samples. How do we get there? And obviously we have got quite a few secondary aims, which we will discuss in the coming slides. Our project lead is Professor Guru Aital, who couldn't be here today, and hence I'm giving the talk. But we have got an array of experts in the university and our clinicians and researchers to help us deliver this project. I just thought it would be helpful if I play a video just to start off with why this project is so important and why it cannot fail.
Bile blockage presents either with a lump along the line of the bile tract or as a blockage of the bile tract. And this can happen due to inflammation or tumors. And some tumors are cancers. The main challenge is in identifying whether it is an inflammation or a cancer.
The commonest symptoms of blockage of the bile duct is patients tend to turn yellow, and they can experience problems with their bowels, so they could see that their stools are pale, their urine will be dark. So those are the typically most common symptoms. One of the other most annoying symptoms is itching, and this will prevent patients to sleep at night. An important step in the treatment of a blockage of the bile duct is to actually identify the cause, because the difference in treat between something which is cancerous and something which is non-cancerous is massive.
Once you've had your consultation, a sample may be taken from your bile duct. This may be one of three. This could be either some cells brushed off the bile duct, or it could be a bigger piece of tissue like a biopsy sample. If you're further down in the consultation process and are having an operation, then you might have a bigger piece of tissue available for examination, but also the surrounding tissue to help us understand whether your lesion has spread to the surrounding tissue.
We are developing a number of technologies, mainly to navigate through the narrowing in the bile duct and map all the narrowing of the bile duct in a detailed way, as well as treat this area so that we can open up for a longer period of time. We have experts from diverse fields involved, which includes robotic engineers, optical engineers, electrical biomedical specialists, physicists, as well as cancer specialists.
From my point of view, having a big project like this, which is going to investigate the bile duct, where it could potentially improve the way we obtain tissue, the way we deliver treatment, stenting, it has big ramifications in the future management of problems with the bile duct.
Our research will transform the field because it will be a step change in diagnosis and the treatment together.
So this is essentially a summary of what our project entails. So we printed a 3D model of a bile duct with duodenum, and we'll be testing our agile robot with this. And the main thing is navigation, trying to get access to this narrow bile duct and going right up to the hilar region. The second part is diagnostics, because we really need to improve how we obtain samples and the accuracy of obtaining samples. And that's the whole point of this work package. The next one is treatment. Unfortunately, majority of patients with tumors in the bile duct are inoperable. Most of them present late, and we cannot do a radical operation for them. But we can deliver local treatment, and this gives us that opportunity. So essentially, we've got 4 work packages. I will just go through them one by one. So the first one is essentially developing a thin, agile, what we call snake robot. The second would be in terms of attempting to deliver treatment into potential tumor in the bile duct. And the third will be looking at the molecular profiling of the tumor cells we get. And work package 4 is to integrate all these work packages together and think of translational studies in the future. So the first work package, this is the one I'm most excited about. So the snake robot. So essentially, the snake robot is a device created by Rolls-Royce. So they use this to analyze their jet engines. So they don't have to dismantle the whole jet engine if there's a problem. What they use is, they use this agile robot which can twist and turn and go and locate a problem. So it's essentially extremely good for diagnostics, but it's highly flexible. So our plan is to develop a snake-like robot which is thin enough that will go into the bile duct. Currently, what we use is a spyglass system where you've got an endoscopy, a normal endoscopy which finds the bile duct, and then we put a spyglass system through the endoscope, and then we go up to the bile duct. But this has also limitations and does not have the flexibility the snake robot has. So this is how the snake robot would work. Is similarly, they have the endoscope. This is the feeding channel, and we would put a robot into the snake robot into this feeding channel, which then work its way up into the bile duct. And you've got somebody controlling the whole robotic mechanism because it's a highly flexible tool. So this is what the plan it will look like. The problem is the current snake robot is more than 1 centimeter in thickness. So we really need to get it down to less than 4 millimeters or 3 millimeters, because the bile duct is assumed to be 4 to 5 millimeters. So these are the cables that go into the control center, and then this will actually go into the endoscope and work its way to the bile duct. Just to give you an idea of size, just comparing it to a 1 pound coin. So it's extremely thin. I know this is a bit of a complicated slide, but what we are trying to show here is where we go in with the snake robot and eventually work our way up to the hilar region. At the tip of the snake robot, these are all the things that will be in it. So the engineers will design specific cables, cameras that can also have Raman spectrometry and 3D mapping. So just to give you an idea of that, this would be the mapping, which will give us accurate assessment of the actual tumor in the bile duct. And obviously, the Raman spectrometry will be able to differentiate between tumor and normal bile duct. And the aim is to improve accuracy of getting a sample. I'm just going to show you a short video. So what this is showing is how the robot will work its way towards the tumor, and this is the 3D mapping. And this is the Raman spectrometry, which we are planning as well. And hopefully this will help us obtain accurate biopsies. Right, work package 2 is highly interesting because the majority of our patients end up having biliary stents because the majority of them actually present with obstructive jaundice, narrowing of the bile duct, and they need these stents, whether it's for pre-operatively before surgery or whether it's to enable them to have chemotherapy or alleviate their symptoms. So our plan is to create nanoparticles that we can put into the stents. So when we do deliver the stents, we can then discharge these nanoparticles through activation, and this will hopefully induce cancer cell death. Again, I apologize for the complex figure, but just very briefly, so this is your bile duct, that's the tumor at either side, and the plan is to deliver the stent here. In the stent, we'll have these nanoparticles. So the plan is we activate these nanoparticles, which will then go into the tumor cells and hopefully induce cell death. Work package 3. So this is where we want to learn more about the current tumors. We want to look at their molecular profiling, what are their biological properties, because we do believe the 3 cancers are different now, and we need to develop more understanding of that. And hopefully, the better the understanding we have, the better it'll help us determine the 3D mapping and also the Raman spectrometry value. Again, very complex slide. Again, this is part of the profiling stage where what we're planning to do is get primary liver tumors, cholangiotumors, and then build models in mice and then test potential treatments and look at their biology. So we've got Sheila and Kevin who are here today. If you want to know more about this, they are here, so please have a discussion with them. So work package 4 is we have to integrate these 3 work packages because there's quite a bit of work to be done in all those 3 work packages. And the plan is then, hopefully, we'll be able to have translational studies after this. But the best thing about this project is, this is not a one-man show. There are experts in multiple fields here with the whole aim to improve the survival and quality of lives of patients with cholangiocarcinoma. I just thought I'd play another video just to explain it better.
Our research project is combining ultra-slender agile robot with electrode-free electrical treatment to tackle the challenges of cholangiocarcinoma. We call it in brief cholangiobotics. Bile flows through a tree-like structure or a river-like structure where small pipelines join up, a long pipeline, and that ends up bile in the small bowel. It can get narrow in any area due to both inflammation and a cancer.
So we need to be able to see cancer better than we can just with our normal eyes. So we're using 2 special imaging techniques. One is called Raman, and for that we shine a laser on the tissue and it makes the molecules ring like bells, and we can detect that ringing and tell the difference between cancer and healthy tissue. The other one is a type of 3D imaging where we use 2 tiny cameras together to create a 3D landscape of inside the bile ducts.
So the problem is that patients have biliary strictures that have to be dealt with by stenting to allow bile duct flow. And one of the issues is that the bile duct stents get clogged with tumor cells over time. We're making 3D cultures that will grow on the stents, and then we're trying to kill those tumor cells using a variety of different methods. And in particular, we're focusing on electric field nanoparticle.
As part of the cholangiobotic research project, we will be gathering high-quality molecular biology and metabolic data to give us a better understanding of these tumors. This data will also be used to train the Raman imaging approach that will be used in the SNIG robot to identify the cholangiocarcinoma for treatment.
The basic idea of continuum robot, multiple discs connected with a flexible element in the middle, and after that we have steel or fishing wires, and by manipulating these cables, basically we can construct the shape we like in order to navigate in confined spaces.
We hope that the technology will be used in real time. So when surgeons are performing surgery in the bile duct, they'll be able to see in real time which areas have cancer and which don't.
over 2 years period, we will be developing 4 different new technologies, which will be ready to be then tested in real patients. And then on, we need to develop individual ones and then put it into a trial in patients. Each of them have got an ability to transform the field. And because we are combining diagnosis and treatment together, we will bring about step change in the field.
Just like to thank UKRI for their funding of this project. This is the team in Nottingham who will be conducting the project. Thank you for listening to me today.